So by the end of today's presentation, you should be able to recognize the key risk factors for developing cardiovascular disease with spinal cord injury, utilize appropriate screening methods, intervals, and norms for assessing cardiovascular disease risk in patients with a spinal cord injury, and determine when patients with a spinal cord injury require a referral to a cardiologist, a nutritionist, a physiatrist, or an exercise specialist. So why is cardiovascular health important in spinal cord injury? I don't know how many of you have patients living with spinal cord injury in your practice, but I'm sure if you do that you've probably encountered some issues with cardiovascular disease. And as a matter of fact, cardiovascular disease is the leading cause of death in people living with spinal cord injury. There's a lifetime prevalence of 30 to 50% for cardiovascular disease, and it may be as high as 60 to 70% given the fact that we know that a lot of people have asymptomatic disease. People living with spinal cord injury have a twofold higher risk of cardiovascular disease compared to the general population. And I want you to think a minute about why that may be. Well, it's because people living with spinal cord injury have a higher prevalence of obesity. They have a lower energy expenditure and thus lower energy or food requirements, lower caloric needs. They're more likely to have central adiposity. They'll have impaired glucose tolerance, insulin resistance, and dyslipidemia. And they have impaired sensation and atypical presentation of cardiovascular disease, which makes it harder to recognize acute coronary events when they happen. So why is there a greater prevalence of obesity following spinal cord injury? Well, it's something called neurogenic obesity. And neurogenic obesity, really, you get sarcopenia, you get abdominal adiposity, osteoporosis, sympathetic dysfunction, and decreased satiety. So we have those denervated muscles, loss of muscle mass, change in body composition, lower levels of physical activity because it's just harder to exercise, limited access to physical activities, and all of that leads to an increased risk of obesity. And we know that more than 50% of people living with spinal cord injury are inactive. We know that in our general population we have difficulty with people achieving the exercise recommendations that we have. And following spinal cord injury, it's just that much harder with the limited access to exercise and the limited muscle availability to be able to exercise. So with that lower energy expenditure, lower levels of physical activity, lack of movement in the lower limbs very frequently, often paralysis in the upper extremities as well, lower thermic effect of food. So we actually see that people living with spinal cord injury don't require the same energy to digest their food. Their thermic effect of food, the amount of energy required to metabolize that food isn't as high. And so each calorie counts a little more after spinal cord injury. So we get that decreased energy expenditure and decreased energy needs. But many people living with spinal cord injury don't actually decrease how much they eat. Sometimes that's simply due to the fact that they don't realize they need fewer calories. Sometimes it's due to the fact that we actually think that there's a change in their satiety. So we think that's a neurologic factor and that it's got to do with neurologic changes and that they just don't they don't feel full the same way that they might have. They don't appreciate fullness after a meal. And so we often see increased caloric intake or relatively increased caloric intake. We also see higher central adiposity. So that change in body composition that we see, that sarcopenia, that increase in adiposity, we particularly see the fact that we see increased central adiposity, which we know is a risk factor for cardiovascular disease. We can see that in body composition studies. So we see that change in fat distribution, and people with spinal cord injury are 58% more likely to accumulate fat around their center. We also see impaired glucose tolerance and an increased risk of diabetes. So there's that altered sympathetic and parasympathetic nervous system functioning. And we've seen that people living with spinal cord injury have higher rates of type 2 diabetes, as well as hyperlipidemia with higher LDL and triglyceride levels, and lower levels of HDL. So impaired glucose tolerance, insulin resistance, and dyslipidemia all increase the risk of cardiovascular disease. And it's simply harder to detect acute cardiac events following spinal cord injury. So if we think about our sympathetic nervous system, the main sympathetic nervous system outflow to the cardiac area is from T1 to T4. So anyone with a lesion above T1, a lesion at the, above T1, so basically anyone with tetraplegia is going to have impact on their cardiac system because they're not going to have the same sympathetic innervation. They're not going to have the control from above in terms of that sympathetic innervation. They will have their vagus, so they'll have intact parasympathetic innervation, and they'll tend to see that decrease in heart rate. And so we may not see that same increase in heart rate with exercise or with activity. They may not feel chest pain the same way. So from T1 to T4, they may have some partial sensation, and then from T5 and below, they should have fairly intact sensation in their cardiac region, but they still may not feel that chest pain the same way or in the typical manner. What people with limited or altered sensation, instead of feeling acute chest pain, they may feel abdominal discomfort. They may feel some vague arm or neck discomfort, similar to the way we'll see somebody with an acute MI who may present with jaw pain or arm pain radiating. We can see that after spinal cord injury as well, but what we don't always see, particularly in patients who are tetraplegic, is that chest pain that's typical of angina. And so patients may present much, much later with an acute myocardial event. You may see that they're getting changes in spasticity. Maybe they're fainting or having lightheaded spells, or maybe they're having shortness of breath rather than that classical angina.